Hello and welcome to part 2 of our podcast on the Untapped Conversations in Behavioral Health. I'm your host, Daniel White, Principal at Pineapple USA. Today we're continuing our conversation on why mental and behavioral health design is full of assumptions that often become default standards. We'll challenge those assumptions, asking questions we all debate quietly, but rarely say out loud. With me, challenging the status quo, are Rachel Romy, Director of Mental and Behavioral Health Design at architect firm HKS, and Martyna Falloni, her colleague, who is a Senior Medical Planner and Associate. Welcome back to both of you.
Thanks.
I'm very excited to be here.
Thank you. So, question 3, jumping into another controversial topic. Rachel, you were actually one of the first people I ever visited on a client appointment in America. I don't know if you know that. It was pretty early on. I think I brought my director. So it was good. We got a good little team in Dallas, who you now lead. So that's fantastic. Thank you for your support. I know you're pretty passionate about this particular question, and you said to me, everyone only ever talks about the worst case in behavioral health, the worst patient. So if it's not all forensic mental health, why do we design like this? Are we really accidentally working against people who are presenting for mental health needs?
I am so glad we're talking about this question. At HKS, we have seen a massive surge of projects that are being funded for forensic patients. So I believe personally that the perception is that forensic population is everywhere, and that is not the case. So when we step back and we really look at the clinical reality, behavioral health is not one patient profile. The ICD classification includes quite literally like hundreds of mental and behavioral health diagnoses spanning from mood disorders, trauma-related conditions, neurodevelopmental disorders, substance use, cognitive disorders, and so many more. My team's favorite is metrophobia, which you should definitely look it up later. It's amazing. So each of these populations has very different environmental sensitivities and therapeutic needs. Forensic patients realistically represent a very small portion of the overall behavioral health population. Nationally, individuals with forensic psychiatric settings really account for a small minority of the psych beds, while the majority of care really occurs in community hospitals and crisis services, outpatient settings, and then the unfortunate reality, like in our jail system, it is very unfortunate but true. But many of the design standards and risk assumptions have been shaped by the highest acuity scenarios because I think we're in part responding to the unknown, which is scary for some people. And then we have a staff crisis. We have retention issues. It's a multifaceted problem, but the disconnect can really unintentionally shape environments toward containment rather than stabilization. So safety has to remain paramount, but safety and therapeutic engagement are honestly not opposing goals. So our goal at HKS is to prove that when environments reduce perceived threat, support regulation, and preserve dignity, they can actually improve safety outcomes. So we don't need to come at every single project trying to make it ironclad against what if a forensic high psychosis patient is on this campus, because that is not a good way to steward our financial resources. Quite honestly, those products that support that direction come at an extremely high premium. And I don't think that it is supporting the lower diagnoses that could come into that kind of environment and see those solutions in their space and ask a lot of questions about what is happening. Why is this the space that I'm being brought into, right? So forensics is something that we do have to design for because it is a reality within our society, but it is not the one and only.
Right, Rachel, and I can imagine the conversations you have with clients are pretty similar to what we have. At every facility says, and this is straight out of a gentleman called Dr. Zeller, founder of the Empath model. Quick shout out for him. Don't know if you're aware of who he is or if you've ever met him. He's a good friend of mine. But I was on a call with him last week, and he said every owner group that I go and see, they all say, "But this won't work because my patients are worse or the worst." And he said, everyone does it. It's the math. They can't all be the worst. The math doesn't work. And he's a particular advocate of open nurses stations, for instance. And that's, I think, one of the big points, the big kickback that caregivers have a visceral reaction to. And they don't see how that can work. So yeah, that's very interesting.
Yeah, I mean, there's so many patients that are voluntary. There's so many first-time presenters. There's so many that are coming to just seek stabilization and support rather than containment. There's some that, come to those empath style environments or crisis stabilization units, short stay assessments, and just want access to tools or to community care really quickly. And so to approach or consider behavioral health in only one light when there are so many different shades is not the reality. I think that's my favorite part, honestly, of sitting in this seat. I love that I get to bring people through projects as they're under construction or hitting substantial completion and just show them like this is a psychiatric hospital. You're standing in a psychiatric hospital because nothing that we do looks like that. Everything that we do has color and art and pockets where people can just sit and de-escalate. We're working a lot in the sensory space for de-escalation. So I think that we're constantly trying to move away from very old, outdated stigma that does not have a place here anymore, and just trying to bring everyone collectively into the future of to what you're just saying about open versus closed care desk. You can't show a staff member that has been sitting behind an enclosed care desk their entire career, an open care desk, and then just immediately expect them to embrace it because they have seen a lot of things, but they haven't seen the rest of the context. They haven't seen the measures that we have provided to help de-escalation. They're only going from what they know based on their own experiences. So I think it takes a village to kind of help to really paint the picture of what the future of behavioral health environments can look like. And that's why we're friends with manufacturing partners. We honestly, in the AEC community, we are cheering for our competitors. That sounds crazy, but we want everyone to succeed because we want humanity to win. We want our patients to be successful and get access to the care that they so desperately need. So I think, um, Zeller, I'm a huge fangirl, but Zeller is right. It's not just forensic.
Yeah, that's great. I think that's the sense of purpose, Rachel, you speak about that gets us all out of bed in the morning, is knowing that we're making a difference for behavioral health patients. I was actually in a forensic unit in the Midwest a couple of weeks back, and honestly, I've been in nicer prisons. It was designed, there was no natural light coming in at all, and I was standing in the staff station thinking, how on earth could you work here as a staff member? And then that protective measure that we spoke about, it was actually an open staff station. But if you've got a closed staff station, if you imagine you've got to go up, tap the glass when you need something, that's a transactional relationship with your someone that's trying to heal you. It's not really imbibing that trust that we spoke about in part one?
Oh, that definitely builds the real barrier. It's not just the architectural barrier that we built in place, but at that point, it's dividing us versus them, right? That's creating the relation of we are here as the patients while they are there because they're safe there. They don't want to be here with us. And we don't want that. We don't want the separation between the caregivers and creating a tension with the built environment or just indication of the separation between those populations. But that's been an ongoing conversation about the nurse station in general. And at this point, we are even getting to the point of challenging if the nurse station as a thing should exist. Should there be more care stations that are decentralized, providing more time with the patients rather than the space to hide, that retreat behind the glass or something, a barrier that exists there while everyone else stays on the unit and is expected to be there.
A good topic. Yeah, that I mean, I can see the place, definitely the place of a nurse's station in a outpatient setting where it's kind of like a reception desk where you go to get the info you need. But yeah, that's maybe one for another podcast, Martina.
For sure, that's a topic on itself. But yeah, just the architectural environment and build environment can take the walls down or build them and emphasize on them. And to the point what we were talking about earlier is creating that environment of trust. And how do we support that trust and connection between all of us that we're here together and we're equals in a way that my feelings are equally as valid as yours and your safety is equally as valid as mine.
Yeah,
And it
that's
might
good.
just be because of my also Irish rebellious nature. Shout out to my friend Daniel White.
How did you know I was rebellious?
I've known you long enough. But I think part of this goes into challenging what is the nurse station and what are the functions that need to be conducted there. Because we have seen the nurse station break down so much in the last 5 years. So, from everything that you have described prior, fully enclosed, completely cut off, physical barrier, to here is a freestanding desk that is completely open. Nobody has a seat there, but you can stand behind it. And it's just for conversations with the patient. It's just to hear patients out, stand there to just like observe the milieu or observe what's happening at dining time. But I think every project is different. I will also say there are some projects that the closed nurse station is appropriate. I know that that's probably not going to resonate well with everyone because we all have hot opinions on this. But sometimes when you are short on space and you need acoustic privacy and you need to talk about what is going on that day with your 7 patients in this subcluster and how to support clear handoffs, sometimes the closed nurse station is the way to go. So I know that it gets a lot of hate mail, but I'm here to also advocate for it.
But Rachel, to your point, that all goes back to assessing our population and assessing our population
Yes.
from multiple angles of what is happening, what are we treating here, but also what are their needs. And as we look at this, we also need to evaluate the cost of the unit because it's better to build a unit than kill the project before it even starts because of the requirements that we need to meet.
Absolutely.
That's a good point. So, Rachel, when you sit down with an architect and you say, right, this is my vision for your new facility, and it's got all sorts of things that they're not used to from their 50-year-old facility that's going to be demolished. How do you take them on that journey of actually helping them, really bringing them along because they're the people that ultimately are key decision makers and really own a lot of this change making mentality. How do you bring them along on that journey?
I love first conversations with clients. I love kickoff meetings. I think that that's when I get the most stoked about the project because I think I approach the conversation a little bit differently. I like to make the first conversation more or less a completely listening exercise on my end. I want to hear what they have to say about their patients because they know their people best from the patient side, from the staff side. So tell me about your patients. Tell me about what, their hardest day looks like. Tell me what would make your job easier. Tell me what kind of space or what kind of, what levels of access would make their day better on both ends, on the staff side, on the patient side. Like if I had 20 square feet of just extra space because of how the column fell. Like, what is something that I could put in this 20 square feet of tiny, tiny baby space that would make somebody smile? Like, that's what I want to hear feedback on. Um, I think that we live for those moments. I think taking staff members like I worked on a project that the campus was built in the late 1800s. And our builders were convinced that the space was completely haunted because it felt very ominous. It felt oppressive. It felt dark. There were remnants in the environment and just like the visual landscape that did not support, waking up, looking out the window and saying like today's going to be a good day. It looked scary. So taking the staff that were then charged to kind of co-create the new environment, the replacement hospital for this campus from what their current state was, from a lot of people, that's all they knew, into here are the opportunities available to you. Here are the options that we now have. I have had a varied past. I used to do a lot of acute care work, and campus master planning. I think that that is a conversation that's a little bit easier, honestly, for acute care partners because they're used to like, what is the new technology? What's the flashy, shiny new object? But behavioral health has not had those types of conversations for so long. So I think we have to be really patient. We have to hear out you know, what the staff and what the client really wants us to know, and to then present them with opportunities that meet them where they're at while showing them we hear you and we love you enough to say, you personally are working too hard. You could be, leveraging these solutions that would either, take your mind from being on constant alert and being constantly fearful of this thing being in your space to like that thing doesn't exist anymore. Like we have alarms, we have cameras, we have or the simple fact of, there's not asbestos in your building. Like boom, reduce your stress level by 10%. But I think that our main goal at HKS is to really show them a holistic plan of this is the full context of what we're bringing you into. So it's not just, don't worry about these doors anymore because here's a different door. It's showing them a wider, larger context of what the new environment will be and talking about their future patient. I think that that is how we have a helpful and successful conversation.
To add to what Rachel is saying, it's the hardest part sometimes is to get users out of their current space, out of thinking how to solve your current space. So hosting those visioning exercises and bringing them into the space of opportunity and understanding of what is the future. Like put your creative hat on that is allowing you to talk about it. And we talk about it all. Let's not parking lot any ideas. There's no bad ideas yet, but collecting the data and then taking it back to the drawing board where we can apply the reality factor on top of it and bring opportunities that we may have not even thought about if someone didn't talk about it as, their dreams of this is how this unit would work. But it's very hard to sometimes get users to leave their day-to-day, this is the unit I work with, can you please fix this door? So having leadership on the client side too, that fosters that relation, that allows them to freely speak about what that future state should be, and bringing more and more of those conversations early on before the project has the budget, has everything is figured out. If we take a step back before we say this is the program, let's look at it and challenge the program that maybe instead of having 5 large rooms, we should have 6 smaller ones because someone needs this. And talking about this openly met with listening to what their population is, what those needs are, is really the key to the successful project setting.
Yeah, it's good. Even just last week, I think it was someone, very nice children's unit in Oklahoma, just a small unit. I think it was 18 bed or something like that. And they said to me, I mean, I don't have all of the post and pre-occupancy data and facts to prove it like you guys do, but they just said, Daniel, since we ordered your furniture, we've noticed a reduction in certain types of behavior. Yeah, I said, it's not just the furniture. The design of the facility was nice. There's a lot of natural light. There was games and interactive things for them to play on the wall. It truly does take a village in terms of personnel, of course, but also different components to make these facilities healing spaces ultimately, which what
You're
this is all
giving the
about.
architectural team kudos.
Yes, and I'm trying to remember who they were, but I can't right now. I just know it wasn't SKS, Rachel, because I remember your projects.
Yeah. Oh, thank you. I love to hear about even those findings. We talked about post-occupancy evaluations earlier, but even those like little moments make me happy to hear about. So thank you for sharing.
That's why I get out of bed in the morning. Sometimes at very unruly hours, shall I say, antisocial hours. The word I was looking for.
And the project we worked together on, Cornwall Health, in Grand Rapids, that one we got so many compliments on the built environment, allowing for those furniture interventions that are there, but if they need to be taken away, they can, to make it a safer room. But we start with the position of trust. We start with everyone has access to all of it. And if you break the trust, we will take some of those amenities away. And your furniture allowed us to cater it that way. The biggest compliment and the biggest takeaway from the FPE we've done on that was the staff telling us that autonomy for those patients allow them to have so much more confidence, and their day-to-day brings them so much more joy because they're not feeling like they have to earn it. That's given till it's taken away if needed. And your furniture really allows for that type of activity and fosters that creative side. In this case, this is a pediatric unit. We have a small desk with a chair within the room, allowing patient to journal, draw, and bring some of those creative parts of their life back to life without having to go and ask stuff like, can I please sit here? Can I do this? They have this creative freedom to occupy their time because of that intervention that we're able to do, partnering with Pineapple and creating a solution that was conductive of it.
Yeah, I love that unit. I saw the pictures when I was with you a couple of weeks back, Martyna. So that was great. Thank you for showing that to me. And really, these facilities have got to work for the staff too. Staff retention. The staff in these units are, from my understanding, and you can maybe comment on this, but it's not like they're higher paid than a nurse looking after other ailments that aren't mental health. And safety is always a consideration, of course. So staff retention is a big thing, but also creating a space that allows staff to build relationships with patients. I feel is so important as well. And the people on the front line working in these units, I hear stories all the time about the amazing things that they do. Like one a while back was someone had come back into a unit to do gardening with the patients on their time off. So just really supporting them in what they're able to do in terms of uh, rehabilitating these patients is, I think, is really important, and the environment's got to support them in that.
I think to that point, there was a big movement a few years ago to make everything patient centric, and I think we're finally going away from it, seeing the staff burnout and the value of staff. That yes, patients are our clients, right? This is the business we're in. We're healing people, but this is really needs to be a spaces that are people centric. We all are human. We all come there together, and for everyone to have better patient outcomes, to provide a truly healing environment, we all need to be at our best. And the only way to be at our best is to provide the environment that is really conducive of that.
I agree. I feel like we pay really generously for procedures, but very modestly for human care time and solutions that support that. I don't know if I ever shared this with you, Daniel, so here we go.
This is
Um,
good in public.
yeah. So I just double checked because I wanted to make sure that I am being honest and accurate. But so I like to celebrate the little moments in the environment that change patients' lives for the better. And I was just remembering this interaction that I had while at San Antonio State Hospital. This was last year in the spring. And I was walking the facility and just looking for our warranty items and making sure that everything was holding up as it should. And I walked out into one of the courtyards and saw these two geriatric friends sitting next to each other on two chairs. And I just looked back and they are for sure, pineapple chairs. And they just looked so happy and they were chatting. And then I saw them holding hands and I was asking the staff member, like, how are the pieces outside holding up? I know that there's a lot of questions that were initially brought to us about, the UV control and if the colors hold up over time and the durability against storms. And the staff member that was walking me into the space was like, let me just tell you, this is a couple. They are absolutely in love with each other. They sit in the same chairs every day. They have sat in those chairs for months next to each other, and at first, they didn't talk to each other at all. They just sat next to each other in complete silence and would just observe what was going on around them. There are some people doing yoga, there are some people, pacing around and, um, you know, talking about the rest of their day with staff members, but he was saying, he was asking us, "Can you guys do a color study, or can you figure out, like, what the magic is that's in these chairs?" Because that's the kind of energy that we want to bring to, like, the rest of our courtyards. There's, the facility is huge. It's 300 beds. There's, adults, there's adolescents, there's a mixed bag of individuals that are under the roof of San Antonio State Hospital. But I just thought it was like the sweetest love story of this couple that just sat next to each other and found relationship in the chairs in the courtyard.
Yeah, that's amazing. Yeah, I love that story. I love working on that project too. I feel like we'd be having a different conversation around that if it was an adolescent unit.
Yeah,
Grateful.
100%. Yes. We can have
So,
that one
well,
later.
yeah, exactly. So yeah, just moving on. Why do we still accept environments that are uncomfortable or ergonomically not very good as a price of safety, of driving safety? I totally get that safety is always a priority for all of us, but just because a product, I often say about specifically about furniture, just because a product has to be safe and it has to function, durability, there's no reason why it can't look beautiful.
Yeah, there's a long-standing assumption that for whatever reason, comfort equals risk. So soft seating has become very synonymous with concealment risks. Molded furniture has become kind of synonymous with safety, but I think that not all furniture is the same, and there's not the same level of care from furniture manufacturer to furniture manufacturer. But we now understand a lot more about sensory regulation, nervous system activation, and environmental stress now. And I think that those findings have really been brought to the table as it pertains to furniture specifically. So we talk about how posture affects emotional regulation, how some furniture supports stimming that supports patient, cooperation or their mood. How texture is grounding, how comfort can reduce agitation and support de-escalation. I think that I wasn't practicing 30 years ago, 40 years ago, but I don't see any remnants in the environments that exist that point to a lot of thoughtful conversations around those things. Not to say they did not happen, but I will phone a friend to see if they did. Um, I guess I will also say that doesn't mean soft furniture works everywhere. Um, Molded furniture performs brilliantly in high acuity and high durability settings, exterior and interior. I think the problem is really when we treat this as an either or decision. So, staff perception matters. If furniture feels unsafe to staff, it won't be used therapeutically. They will put it in a space where it will probably not be used, period. And infection control realities have to be grounded in evidence and not marketing claims. Like, you're going to have to show us this is going to hold up against whatever gets spilled or dampened on site, and then whatever cleaning materials the staff are going to use on the product. So, hybrid environments where spaces vary based on acuity and observation level really often perform better than one universal solution.
And to add to that, leveraging our partners, Daniel, on the previously stated Corwell project, we wanted the soft chair, and I don't remember the name of it, but it's on your little image. And it's one of the patient favorites. The staff wasn't sure about it. Infection prevention wasn't sure about it right away. You guys graciously provided us with a model that was there for a year, put in an ED, put through test. And then they came back and said, this is amazing. We love it. It outperformed everything we thought. And it creates this space for patients to feel comfortable while providing a safe environment. And we ended up putting them in every single room. But initially, the reaction was absolutely no, this will never work here. So leveraging those opportunities for a mock-up or for a trial, or bring in the piece of furniture, or take the team to the hospital that is already built to see those in use, is really underrated. And having those conversations early on that, hey, we can bring this all to you for you to feel confident. And as we see, like what Rachel was saying, if the staff feels confident about it, they're going to use it, they're going to leverage it. If they don't like it, or it creates operational deficiencies or some insecurity around that, it will be put in a corner in a way that will never be used. So really bringing this forward to them and allowing them to make educated decisions that are backed by them feeling confident allows us to move confidently with the design solution and furniture selection, or even product selection for the unit itself.
Yeah, that's the Zen chair, I believe. It's a very casual seating position, if I remember the project right.
Yes.
Yeah, no, that's amazing. And I keep referring back to my time in the UK just because it was so much different. But in I've gone into units in the US and come out and described it as a plastic jungle. Because in the UK there's generally a mix, even in the most secure environments, there's a mix of upholstered and plastic. Maybe some in the dining spaces for infection control and hygiene. That's plastic makes the most sense. I totally get that, and I also get that upholstery is not suitable for every environment. But I think there's a misconception as well that we're disrupting. And the misconception being that plastic has to be uncomfortable. I don't think that's the case. And I think, just even going back into a previous podcast on macroergonomics, and how the chair functions. We've got people that sit for hours on end in our plastic molded chairs, and we win a lot of business based on comfort. Obviously, that's subjective, but designing for the masses in terms of body types is quite key for us to ensure that the furniture is really working to support that particular patient.
But I think that goes back to defining what is that we want to achieve, right? There's, as Rachel was saying, there's a place for molded furniture that has outperforms other ones, but then where we can soften it, let's do it. And to your point, Daniel, it doesn't mean it has to be uncomfortable. It doesn't mean it has to be plan B for those things. It's really understanding the activities and supporting them in the best possible way we can to create that space that people want to be in. There's nothing worse if we create spaces that are there just to be there and they're unused. That's wasted money, time, and resources because it could have been something else that would cater to the need, that will bring engagement.
Absolutely. I love that word engagement with staff as well, creating flexible spaces too. I've been in a unit not that long ago where they didn't have enough furniture. They had hardly any furniture, but they had a lot of patients. And patients were standing in little groups. They were standing slouched against the wall. There was other patients that were walking round and round just in circles. And it was very inhumane. It was a point of reflection for sure. But you think about how that escalates behavior. I don't want someone to walk past me every 30 seconds. I probably would act out if someone did that to me, particularly if I was having the worst time of my life. So yeah, just making sure that all of these things work together to really allow staff to do what they're there to do, which is to heal patients.
Yeah, and I think, Pineapple's work in particular really demonstrates that safety and comfort don't have to be competing priorities. I know that you guys take a ton of time to look into forms that support posture. We have had I don't know how many conversations about what the feedback is from clinicians, from patients on the comfort of different pieces. I know we've, suggested small changes and you guys have picked them up. Like it's kind of it's a feedback loop, right? We hear feedback from the use case. We bring it to you all, and you're always very cooperative. And it has rendered a lot of great success because our clients want to work with people that take their considerations and their feedback seriously. So I really appreciate the relationship that we have with you all.
I think again, it's just an example of where interdisciplinary conversation really, really works for the patient. I've got some very exciting things to show you as well, Rachel. We'll need to do a sidebar meeting for sure. I think you'll be very impressed with the level of innovation we're putting into some new products across different product groups as well, not just furniture, but also lighting and bathroom spaces, particularly lighting, where giving the patient a little bit of control in their own environment, giving them a little bit of an autonomy, where in a place where typically they don't have a lot of choices. I think it's going to do great work for de-escalating challenging behavior.
Let's see it. Come on down.
Yeah,
Or Rachel, you come here because Daniel's office is right across from the street from my house, and I've been lucky enough to be in their showroom a few times. Daniel, to the other point of that is we really appreciate the education you guys bring to our team. That the two-way street of trading information, we listen to what the clients need and want, but you also tell us what industry is bringing to the table and educate us on how best deploy your products. I think it was 2 years ago, you brought half of the Detroit office through your showroom to show us the things you guys are working on to allow us for some feedback at the time before you finalize the product. And not only we felt like that gives us a little bit of autonomy around, we can freely speak to the owner and confidently say, we have solutions for that. Yes, they're not built environment, but we know how to do it. We have those partners that we can go back to and not only have a let's call it off-the-shelf solution that lives in your catalog, but we have the relation to, if there's something you need that is very specific, we know who to call and how to get this going.
But it's great. Again, an example of how we want to be thought leaders in this space and leading these conversations on the impact we have on behavioral health. Because we actually took, and I don't know if I've shared this with you, probably because you'll tell me off that it wasn't fair that you guys weren't included, but we actually took 6 people from HKS across a variety of offices, but you're working on a very large project in one of the southern states, and we took your team to see a new forensic mental health unit in Dublin, and we got a presentation from one of the leaders there on the unit and how it was working, why they did certain things the way they did it, and how much thought had gone into it. That's for anyone that's interested, that's the Central Mental Hospital in Portrane in Dublin, and it was really inspiring to see. And then after we did that, I actually got in a bit of trouble from your team because I flew them Daniel style, I'll say. I flew them pretty early the next morning, probably, and they had jet lag and everything else. I think the flight was at about 7 a.m. I flew them to our UK headquarters, and we had a workshop on product development. Where are the gaps? What do we need? How could we uh, bring this product out in a wider color palette? How can we really solve real life issues through the use of furniture? And that's just an example of how we design product. Happy to bring you into conversations like that as well, of course.
I did hear all about this this trip from our team, and thank you for taking such good care of them. They loved the experience and had lots of lessons learned to share on the way back. As a mama, I feel like trips to Dublin are a little bit challenging to schedule, but count me in sometime in the future. I think my little guy will graduate in about 10 years, so put me in.
Okay, we'll work out where you are in the world in 10 years' time, Rachel.
Yeah.
But meanwhile, you're more than welcome to come to Michigan, right? We would love to have you here.
I would love that.
So I just circling back, I feel like a lot of the things that we've discussed, one of the major barriers is cost. Budget. We don't have the budget for that. We don't have the cost for that. I think there's a lot of quick wins, but do you think everything needs to cost money? Do you think there's quick wins that we can make easily by having more thoughtful conversation and dialogue?
I think there's opportunity for operationally improving things. There's opportunity to reworking what we already have. It doesn't always need to be start fresh. There's a lot of opportunities in reusing things that are working well, that are existing, and building upon those, building positive reinforcement of activities, positive reinforcement of the way staff is interacting with patients in existing conditions. But to your point, there is a huge need of behavioral beds with multitude of different diagnoses. So we definitely are up against the crisis of we need to infill the void and provide those spaces. But Rachel, along with obviously the whole HKS team, we've been putting a lot of effort into trying to understand how can we provide flexibility for those different diagnoses that we can support them while having units that are, to the point of our earlier conversation that we had in part 1, they're not 100% forensic. That's not the best use of our money. But understanding what is that balance between different types of what are we facilitating, what is the safety level, and leveraging the safety risk assessment, as well as looking with just a little bit more thought through on what we're trying to solve and trying to select appropriate interventions if they're architectural, if they're just staff interaction, and trying to improve on the way as a whole this is working. Rachel, I will throw it to you. I'm sure there's more to it.
Last input, Rachel, on the podcast.
Yeah. I think cost is absolutely a real constraint, but one of the most effective ways to manage cost is definitely through operational understanding. So when we take time to really understand how the unit works, how patients move through the space, where staff spend time, where escalation tends to occur, and how therapy is delivered, we can make so many smarter decisions. So that could mean, reducing clutter, improving circulation so staff interventions are less frequent. It could mean creating a space that has much clearer sight lines, but it's flexible in use. So, like the noisy activity / dining room spaces. So, creating environments through the furniture selection to the lighting selection to other and just how we organize the space to be flexible. Huge cost savings. We talk a lot about the amenities that we put in the environment that are not redundant, so they have to be shared between units. So things like a gym, huge footprint, right? But massive benefits because you're giving access to recreation, and recreation supports de-escalation and physical health. So how you organize the operations around how does unit A through J get access to the gym? That is operational. That is not an architect's. We track the circulation. We look at all of the opportunities for any kind of cross circulation or cross contamination to happen, but ultimately that's the decision of our client of when do they want to bring unit A to the gym, and how does that work in the rest of their therapy. So I think that you're pointing to a lot of the other kind of cost levers that we have. It is not any one single, division's responsibility to VE out what their desires and hopes and dreams are. That is really unfortunate when you see that happen. I will say, when you look at the other divisions outside of furniture, it's a much higher impact. Furniture is not the biggest, most expensive cost to a project. So we typically do not want to start with furniture or art or other things that are not going to be a higher impact when we do find ourselves in a cost conversation. I think that and my husband is probably going to give me sideways looks for this, but mechanical, can we just talk about how expensive mechanical is to every project, electrical, plumbing? So I feel like maybe if we want to bring the cost down, let's talk to our MEP partners first before we start to point fingers in Pineapple's direction.
That sounds like a family fight waiting to happen. But I love that you've said that. I don't understand VE. We go through years of conversation, and then we change something for the sake of budget. Don't we need to do more fundraising? Anyway, that's a topic for another subject. It's a topic for another podcast, I should say. Well, guys, it's been great having you on the podcast. I feel like time is up. We've run out. Really appreciate the conversation. I love that. So what's clear is behavioral health design. It doesn't need more defaults. It needs more honest conversations like these. If we're willing to question what we as humans have normalized, we can create healthcare environments that aren't only safer but more humane. So thank you everyone for listening to Healing Spaces Mental Health Design Dialogue, and we'll continue the conversation next time.
Thank you.
Thank you so much for having us.